Hi, good evening, everybody. I'm Ryan. I'm one of the Carillion TGY5 Child and Adolescent Psychiatry Fellows, and I'm going to be here with you today to talk to you about this research educational project that I did. And I'm here, I know Dr. Adams is here with me. I'm not sure if Dr. Kablinger is here. Maybe she's here, I didn't see her, but.
She's here in spirit. She is at the VT home game today.
Well, she is here in spirit, so.
She was here earlier.
All right, so to kind of get started, I like to start with a little bit of history to kind of introduce why I think this project is important. If you all were psychiatrists practicing in the early part of the 20th century, your practice would have been probably either one of two ways. It would have either been sort of working in an asylum, kind of sequestering people with mental illness away from society, or maybe you would have been working in an office doing psychotherapy. But this all started to change around the end of World War II. There were a couple of different, this was the time of sort of the, when chemistry was beginning to discover how we could manipulate molecules and make new medications. And there was a couple of different, almost simultaneous, sort of serendipitous discovery of different chemicals that worked to change people's mood. And this kind of caused an explosion of interest about these new chemicals that could help for different mental health conditions. If you look at this first picture up here on the upper right, it sort of talks about a little bit of the tension that caused, sort of that people were used to doing psychotherapy, but suddenly there is this medication, and maybe if you take this medication, it can help you do psychotherapy better. As time progressed, we got into the 80s and 90s, we developed new classes of psychotropic medications that were safer and as effective and more effective than the previous psychotropic medications. And this kind of created this controversy within the field. You can see a couple of books, not recommending these books, but just to sort of talk about, get an idea for some of the controversy that this caused in the field of we were all used to doing psychotherapy with these patients, and now there are medications. Is that a good thing or is that a bad thing? Sort of fast forwarding to the kind of the 21st century in the era of insurance reimbursements, and we all have busy clinical schedules and managed care. Psychiatry as a field has moved more and more away from practicing psychotherapy and towards the prescribing of medications. And this has influenced how psychiatrists practice, and it's also influenced how psychiatrists are trained. More and more the training is focused on how to prescribe medications rather than how to do psychotherapy. Couple of just sort of research studies to talk to you about. So this is a study in 2022 analyzing prescribing and therapy patterns over about a 10-year, that's about a 20-year period or so, and just looking at how the use of psychotherapy in patient encounters by psychiatrists fell by quite a bit. And by the second evaluation point in 2016, many psychiatrists were not using psychotherapy at all. Moving on to medical education, the survey of residency training directors just found that the training directors were having difficulty integrating psychotherapy into the training, just difficulty with finding supervisors, finding patients, and then this tension to sort of be scheduling their trainings with more medication management visits and less psychotherapy. And then finally, this last study here, just kind of doing a narrative analysis, looking at resident perspectives, just this idea that residents are not feeling like they receive adequate training in psychotherapy, they're not feeling comfortable in performing psychotherapy, and therefore they just don't do it. So this brings us to our approach in this this research project. Our hypothesis was that if we could develop and deploy sort of a focused educational intervention to psychiatry residents kind of before the start of their third year, which is traditionally the time in our program anyway when psychotherapy is emphasized, that the residents will feel more comfortable with knowing about psychotherapy. They'll feel more comfortable with answering test questions, and hopefully they'll also feel more comfortable with using psychotherapy in practice. We developed 6 hours of didactics administered in 2-hour segments, 3 weeks apart over 3 separate weeks. We also received IRB approval to develop and deploy a 10-question survey. We asked about various ACGME psychiatry milestones related to psychotherapy. We asked about comfort with psychotherapy. We asked about comfort with doing psychotherapy, answering test questions, and then also just interest in further psychotherapy education after the conclusion of the didactic series. And then finally, the didactics were sort of in the framework of the psychiatry residency's normal didactic curriculum. And so as a part of that, the psychiatry residency gathered narrative feedback afterwards, which they were gracious enough to share with us. I want to talk a little bit about what we actually talked about in these 6 hours of didactics. Kind of in contrast to sort of everything I'm doing right now, it's different. I tried to make it be much more interactive than me just kind of talking to you all and you sitting there passively listening. Tried to use more of sort of interactive chalk talks than no PowerPoint presentations. We tried to focus on having video examples of different famous psychiatrists and psychotherapists actually performing psychotherapy. We did some large group discussions and then kind of small group breakout sessions and then kind of coming back to the large group again. In terms of what we actually talked about, I spent 1 hour on each of these different psychotherapy modalities. With motivational interviewing, we talked about kind of its use in helping people with enhancing motivation for many things, kind of most pertinently alcohol and substance use. Talked about kind of enhancing motivation and reflective listening. For humanistic therapy, we have a picture of Dr. Rogers over here on the left. Talked about kind of his humanistic approach to psychotherapy, his ideas of unconditional positive regard, actualization, and conditions of worth. For CBT, we talked about the cognitive behavioral triangle, cognitive distortions, and we watched a video of Judith Beck actually doing CBT on a patient. For DBT, dialectic behavioral therapy, that's where we did some of the breakout groups, kind of each of the groups would have a different kind of DBT skill that they all talked to each other. And then we watched a video of Marshall Lenahan, the developer of DBT, actually doing DBT. For psychoanalytic therapy, it's kind of the Freudian therapy. We spent a while kind of talking about the history of Freud, Freud's structural model of the brain, the id ego and the superego. Talked about his psychosexual model of development. And then moving on to psychodynamic, we talked about kind of how Erikson got some of his ideas and expanded some of the ideas from Freud. Talked about anti-Freudian defense mechanisms and watched some videos of people doing kind of snippets of psychodynamic therapy with patients. For the statistical methods, like I mentioned, we got the IRB approval for this 10-question survey, and I realized that the text might be a little bit small here, but essentially we asked them each of these 10 questions that was rated on a comfort scale of 1 being the least comfortable, 5 being the most comfortable, kind of asked them to rate their comfort. We administered the survey before the didactics, and then we administered the same survey after all the didactics were completed. And then we analyzed the results. In terms of the results, 14 initial surveys were completed, but we had to make sure that we were getting the same sample before and after. And so we wound up with 10 surveys being able to be matched to the post-intervention. So they were included in the analysis. The results for increases for all the questions were statistically significant. And then we also received narrative feedback from 14 different residents in 3 different feedback categories. This is kind of the main kind of meat of our research project here. And I know this might also be a little bit difficult to see, but with kind of the graph here, the blue line is the average scores for each of these 10 questions before the intervention, and the orange line is the average for after the intervention. Of notable, 1 is the lowest number that's possible. So many of the residents felt that they did not know very much about psychotherapy and weren't very comfortable in it, and many of them felt that they were much more comfortable afterwards, and there was certainly very high interest in further didactics about psychotherapy kind of based on the results of this survey. The narrative feedback, it's a little bit more difficult to kind of summarize succinctly in a slide, but it was kind of reviewing it. It was pretty overwhelmingly positive. Many of the residents voiced that they really enjoyed the format, the kind of the eclectic format and the interactive format. And sort of the general consensus in reviewing the feedback was that they really seemed to enjoy this, and they found it was very useful for them, and they were really interested in receiving more education and didactics like this. So in conclusion, our hypothesis with this was that this relatively brief educational intervention would affect a significant change in the residents' interest in and comfort with psychotherapy. And I think kind of based on what we did here, we showed that that was true. There are a couple of different ways I think that this research could be expanded on. For one, the post-intervention survey was directly after the didactic feedback, and they just took their in-service exam. And so we've been talking about the possibility of comparing the pre-intervention to post-intervention scores, especially on the psychotherapy component of the in-service exam. And also just assessing if it's possible to take this intervention and generalize it to different settings, different speakers, and see if the same result would still hold. So these are my sources and my image credits, and I wanted to open it up to see if anybody had any questions.
So much, Dr. Thoughts, questions? Thoughts or comments or questions for Dr. Ritch?
I'll just say, I think you did a wonderful job, and I appreciate your presentation. And I think one thing I can observe when you came to me with the idea for this is that you felt very strongly that you would not do PowerPoint. And I think that is a big part of why the residents liked it so much. So like a detail of this whole process was how much we needed the whiteboard. That was a big part of the whole research process. But Dr. Ritch wanted to do a chalk, that is his term, not mine, but he wanted to write on the board. And I think the way you engaged the residents was why they really liked it. I was really impressed for the lectures that I was there when they gave this feedback that you had given them the homework to do the CBT homework we often give to patients to track their mood for the week, right? And they had to come back to you. And they were like, oh, we couldn't do it. You know what I mean? I felt like that really built the empathy for their patients. And I loved the way that you gave them tasks and you engaged them with each other and you didn't use PowerPoint. I think that's why they loved it so much. And I just want to give you so much credit. I think it was fantastic.
And I'm sad that this presentation was sort of the opposite of my. I guess I could have used the whiteboard over there, but wouldn't have recorded well. Thank you so much. Any other questions or comments or thoughts?
So was this a one-year program?
Yes, I'm leaving next year, so I have to
Okay.
find someone to pass the torch on.
And how many people participated? How many learners participated?
16 altogether, but due to different residents being there or not being there, 10 surveys that we got all together. I think I saw a question back there.
I was just wondering if anyone on your team has any plans to track whether your graduates eventually use psychotherapy in their practice, whether this influences the future.
That's an interesting idea. I have to think of how we would actually measure that. That's an interesting idea. For sure.
Something.
Sure.
Don't let it go just because you're leaving. Keep us going.
It's more of a comment. I do think that as somebody who's done curriculums for residency programs, it is hard when faculty or in your case, fellows have great lectures and then move on. So, to find a way to, even if it was just putting some sort of script together that you could potentially pass down to another faculty member, I'm sure whoever does the didactics would appreciate.
Sure. I'm trying to find someone to pass the torch on to.
Yeah.
Anybody else?
One more. I thought I saw one more hand go up.
Did you get a chance to practice with actual patients, or was all just interdepartmental learning?
No, they practiced on each other a little bit, but no actual in vivo patients with us. No.
Is that part of the plan moving forward, or?
So the residents get they get a chance to practice psychotherapy on real patients in their third year, which is sort of a part of the curriculum. Yes, for sure.
Thank you. So, one more.
Sorry, one is very psychiatry specific. In the psychoanalytic section, did you mostly talk about Freudian psychoanalysis or did you include other psychoanalytic practices?
I started off with Freudian psychoanalysis, but I tried to broaden up a little bit, talking about Erikson and Anna Freud. So I guess partially Freud too, but Anna Freud as well, sort of as the time permitted.
One other thought, kind of piggybacking on the comment about tracking forward on whether they incorporate more psychotherapy into the practice, maybe more sort of, do they look for further training after they've graduated? Because 6 lectures, you wouldn't be able to, without all focusing on one topic every 2 hours, wouldn't be enough to do your own psychotherapy, but.
No, for sure. My goal was just to,
maybe if they're interested enough to get further training would be.
just to generate some excitement.
I love that this work and all the scholarship that we really do, the best of it, really encourage us to have thoughtful questions like this, right? And to have suggestions for how we might do the person to whomever you pass the torch. And if you stay engaged with it in some fashion, you know, just evolving the project. I love hearing the questions.
For sure.
Thank you all.
Thank you so much.
Thank you.